My name is Rakeen from Care, and today, as part of this month's Health Talk, we'll be talking about rheumatism in Malaysia. Statistics, causes, pathophysiology, risk factors, treatment, and rehabilitation. Why rheumatism matters. Rheumatic and musculoskeletal conditions limit movement, work, and independence, as well as quality of life. About 1.71 billion people worldwide live with musculoskeletal conditions, and it is the leading contributor to disability globally. In Malaysia, the biggest practical issue is not just pain, it is delayed recognition, lost function, and limited access to long-term rehabilitation. So rheumatism is an umbrella term. It describes many painful conditions affecting joints, muscles, bones, and connective tissue. For example, we have inflammatory arthritis like rheumatoid arthritis, psoriatic arthritis, and spondyloarthritis. Degenerative joint diseases such as osteoarthritis from cartilage wear and whole joint changes. We have crystal arthritis, gout from uric crystals causing sudden inflammatory flares. Systemic autoimmune disease like lupus and related disorders can affect joint and organs. And we have soft tissue pain such as tendinitis, bursitis, fibromyalgia, and regional pain syndromes. The key idea is rheumatism is not one diagnosis, and the correct treatment depends on the cause. But what can we say with confidence? Malaysia has service level data and studies, but no single national rheumatism registry. So a global systematic review found mean rheumatoid arthritis, which is RA, point prevalence around 0.56%. Applied to about 34 million Malaysians, this suggests roughly 190,000 people, maybe, living with rheumatoid arthritis in Malaysia. Malaysia's rheumatology clinics also manage gout, osteoarthritis, lupus, and other inflammatory arthritis. And aging, obesity, and delayed specialist care can increase disability even when disease numbers are stable. When joint pain needs attention. So patterns help distinguish inflammatory disease from ordinary aches. So for example, morning stiffness lasting 30 to 60 minutes or more suggests inflammation. Swelling and warmth. Persistent swollen joints should be assessed, especially hands, wrists, knees, or feet. Symmetry or many joints. Both size or multiple joints can point to autoimmune arthritis. Repeated flares, sudden severe toe, ankle or knee pain may be gout. Systemic clues, fever, rash, weight loss, or eye pain or breathlessness need prompt care. Seek early care. The first months of inflammatory arthritis are a window of opportunity to prevent long-term damage. So different pathways can lead to rheumatism. The pain pathway matters because treatment for each type is different. We have mechanical wear affecting cartilage and bone changes such as osteoarthritis, often knees, hips, and hands. Immune inflammation, immune system attacks synovium, which is your joint, such as rheumatoid arthritis, lupus, psoriatic arthritis. We have crystal deposition, urate or calcium crystals trigger flares, such as in gout and pseudo-gout. And we have pain sensitization. Nervous system amplifies pain signals, such as in fibromyalgia and chronic pain states. So one person can have more than one pathway, for example, osteoarthritis plus gout. What happens inside an inflamed joint? Rheumatoid arthritis is the clearest example of immune-driven joint damage. Firstly, genetic and environmental trigger causes immune cells to activate, which leads to synovium becoming inflamed, and the pannus erodes the cartilage and bone, which leads to pain, swelling, and stiffness, and can end up in loss of function if untreated. Treatment interrupts this cycle by reducing inflammation early and keeping disease activity low. So here are 5 conditions people often call rheumatism. Recognizing the pattern helps patients describe symptoms and seek the right care. Rheumatoid arthritis, which is small joints or hands or feet, prolonged morning stiffness and symmetrical swelling. Osteoarthritis, which affects the knees, hips, spine, or hands. Pain with use, stiffness usually shorter. Gout, sudden severe flares, often big toe, ankle, knee, linked with high uric acid. Lupus or connective tissue disease. Joint pain plus rash, mouth ulcers, fatigue, kidney or blood problems. Spondyloarthritis, back pain, improving with movement, heel pain, psoriasis, or bowel or eye inflammation. A disclaimer: do not self-diagnose. Many conditions overlap and need blood tests or imaging only when clinically appropriate. What raises the chance of disease or disability? So some risks cannot be changed, but many disability risks can be reduced. So here are 2 categories: not modifiable and modifiable or manageable. So under not modifiable are things such as older age, the female sex for rheumatoid arthritis, family history and genetics, previous joint injury or deformity. For modifiable or manageable risks, smoking and secondhand smoke, obesity and low physical activity, poor sleep, stress and low mood, high purine intake or alcohol in gout-prone people, and delayed diagnosis and irregular follow-up. So risks does not mean blame. The goal is early detection and practical risk reduction. So the journey from symptoms to diagnosis, a clear history and examination are more important than screening everything. Firstly, the story. We need to know where, when, morning stiffness, flares, triggers, and family history. Only then, examination for swelling, warmth, range of motion, tenderness, and function. Proceeding with tests afterwards, like blood tests and imaging chosen according to the suspected disease. And lastly, referral to early rheumatology referral for persistent inflammatory arthritis. You can ask your clinicians, do I have signs of inflammation or joint damage? Good care is more than pain relief. Modern management aims for function, protection of joint, and participation in daily life. So we want to control inflammation, which reduce swelling, stiffness, and active disease. Prevent joint damage. Treat early to avoid deformity and disability. Manage pain safely. Use medicines and non-drug approaches together. And protect independence. Maintain work, family roles, sleep, and mental well-being. Treat to target principle. Monitor symptoms and disease activity. Then adjust the plan until the target is reached. So medicines, we look into the treatment. Medicines, what each group is for. So medication choice depends on the diagnosis, disease activity, safety profile, and patient priorities. We have pain relievers or NSAIDs. Short-term symptom relief do not prevent autoimmune joint damage. Then we have corticosteroids. Fast inflammation control. Use carefully because long-term side effects matter. We have CS DMARDs, methotrexate, and others. Slow inflammatory arthritis progression. Biologics and targeted DMARDs escalation options when disease remain active despite standard therapy. And we have urate lowering therapy, which helps to prevent gout flares by lowering uric acid over time. Safety reminder: never start, stop, or combine medicines without medical advice. You should monitor blood tests for further decisions. Rheumatoid arthritis, a simplified care pathway. So Malaysia's Ministry of Health guideline emphasizes early diagnosis, DMARDs, and multidisciplinary care. Firstly, persistent inflammatory joint symptoms will be followed up by early referral and baseline assessment. Then start CS DMARD, often methotrexate if suitable, and then we monitor, aim for remission or low disease activity, or escalate if target not achieved. Non-drug care runs throughout, so we have education, physiotherapy, occupational therapy, podiatry, dietetics, and shared decisions. So in the multidisciplinary care team, medicines control disease, rehabilitation, and education help people live well. So we have patient education to know the disease, medicines, and warning signs and flare plan. We have physiotherapy for exercise, mobility, strength balance, and pacing. Occupational therapy for joint protection, splints, home or work adaptations. We have podiatry for your footwear, insoles, and foot pain management. Then dietetics for weight, gout diet advice, nutrition for long-term health, and shared decisions, set goals together, pain, function, work, family, and daily life. The main message is people are active partners in care, not passive recipients of treatment. So how does rehabilitation restore confidence and function? Rehab should be individualized, progressive, and linked to their daily goals. Firstly, assess the pain levels, swelling, mobility, strength, balance, walking, and daily activities. Calm flares, joint protection, pacing, splints, heat or cold, and safe movement. Third, rebuild, range of motion, strengthening, and low impact aerobic exercise. Fourth, participate, return to work, hobbies, prayer positions, household roles, and community life. So the World Health Organization states that musculoskeletal conditions are among the largest contributors to rehabilitation needs. So here are some daily habits that protect joints. Small, repeated actions can reduce disability and support medical treatment. Move every day, such as walking, cycling, swimming, or gentle strengthening. Use pacing, alternate activity and rest rather than stopping completely. Keep a healthy weight to reduce load on knee, hips, and feet. Stop smoking. It raises rheumatoid arthritis risks and worsen treatment response. Track flares, triggers, medicines, and questions for the next visit. So during a flare, reduce intensity but keep gentle movement if safe. Complete rest can increase stiffness. What should you do when the symptom gets worsened? A flare plan reduces fear and helps people know when to seek help. So pause and protect. Reduce heavy tasks. Use splints, assistive devices, or pacing. Soothe symptoms. Heat for stiffness, cold for swelling. Follow the medication plan. Record the pattern. Which joints, severity, triggers, fever, rash, medicines missed. Seek urgent care. Fever, severe, new swelling, chest pain, breathlessness, or eye pain. Do not repeatedly self-medicate with leftover steroids, NSAIDs, or antibiotics. Check with a clinician. Where can people get help? Access usually starts in primary care, then moves to specialists and rehabilitation services when needed. So firstly, you can go to Clinic Kesihatan for your first assessment and symptom control, followed up by hospital physician or rheumatology referral for persistent inflammatory signs. And number 3 is rheumatology and allied health, DMARDS, monitoring and rehabilitation. Number 4 is community support, education, family support, and self-management. For example, UMMC describes clinics for lupus, connective tissue disease, and inflammatory arthritis, plus daycare for biologic infusions and musculoskeletal ultrasound. So a tip for patients: bring a medicine list, flare diary, and photos of swollen joints and questions to every visit. So here are 4 messages to correct common misconceptions. Public education works best when it replaces fear with practical action. So the myth that says it is just old age, whereas the fact is some rheumatic diseases are autoimmune and need early treatment. The myth exercise will damage joints, whereas the fact is the right exercise improves strength, mood, and function. Myth: pain always means damage, but fact is pain can come from inflammation, sensitization, and overload. Myth: medicines are only for pain, whereas the fact is we have medicines like DMARDS that can prevent joint damage in inflammatory arthritis. So the safest message is persistent swelling, prolonged stiffness, or repeated flares deserve assessment. So keep moving, treat early, protect function. Rheumatism is an umbrella term and diagnosis matters. Malaysia-specific prevalence data are limited. Burden is likely substantial and rising with aging. Inflammatory arthritis needs early assessment and treatment to prevent long-term damage, and rehabilitation, exercise, and self-management are core treatment, not extras. So you should know your flare plan and follow up regularly. That's all. Thank you very much.